Hello everybody. Today we are going to discuss physiology of fetal heart rate control. The fetal heart rate control, just like in adults, is controlled by both autonomic and somatic components of the central nervous system. The autonomic nervous system controls visceral functions and is composed of sympathetic and parasympathetic systems, which are constantly interacting with each other to increase and decrease the heart rate, respectively. The agreement reached following this interaction is indicated by the baseline fetal heart rate. In addition, the constant fluctuation between sympathetic and parasympathetic nervous system creates the bandwidth of this baseline, which is observed on the CTG trace as the baseline variability. Somatic nervous system is responsible for voluntary control of body movement via skeletal muscles, and it accounts for the occurrence of accelerations on the CTG trace. However, accelerations may also be seen in anesthetized fetuses, indicating that somatic nervous system activity may also be centrally mediated. During labor, a fetus undergoes the most stressful journey of his entire life and will have to use all his available resources to adapt to the constantly evolving and rapidly changing intrauterine environment. Every fetus will have his own unique physiological reserve, which may be modified by a combination of antenatal and interpartum risk factors. Parasympathetic nervous system. The parasympathetic nervous system is responsible for activities that occur when the body is at rest. In contrast, the sympathetic nervous system is responsible for the fight or flight response, which is essential for survival. The, the parasympathetic system will attempt to reduce the fetal heart rate in order to maintain a positive energy balance in the fetal heart in response to any hypoxic stress. This is because, unlike adults, a fetus cannot instantly increase the oxygenation to its myocardium by increasing the respiratory rate as it is immersed in a pool of amniotic fluid. Parasympathetic activity is mediated by two kinds of receptors: baroreceptors and chemoreceptors. Baroreceptors, they are stress receptors found in the carotid sinus and arch of the aorta. During labor, with the onset and progression of uterine contractions, both fetal head and umbilical cord may undergo repeated compression. Increased peripheral resistance secondary to the occlusion of the umbilical artery leads to an increase in fetal systemic blood pressure and resultant stimulation of these baroreceptors located in the carotid sinus and the aortic arch. Once stimulated, the baroreceptors would send impulses to the cardiac inhibitory center in the brainstem. This is in turn inhibits the atrioventricular node situated within the heart via the vagus nerve to slow down the heart rate. In addition, stimulation of the baroreceptors also decreases the sympathetic stimulation of the heart. Such baroreceptors mediated decelerations will be seen on the CTG trace as variable decelerations secondary to umbilical cord compression. As these are generally short-lasting episodes related to uterine contractions, the fetal heart retains to the baseline quickly, and they do not expose the fetus to any hypoxic injury. Therefore, in the absence of other abnormalities on the CTG trace, like unstable baseline or changes in baseline variability, the presence of early or Typical variable deceleration should be viewed as pure mechanical stresses during labor. Hence, they do not require any interventions other than continued observation. Chemoreceptors. These are found peripherally on the aortic and carotid bodies and centrally within the brain. Chemoreceptors are stimulated by changes in biochemical composition of the blood, responding to increase hydrogen ion and carbon dioxide accumulation and low partial pressure of oxygen. During labor, the activation of these receptors causes stimulation of the parasympathetic nervous system, which decreases the fetal heart rate. Nonetheless, unlike the short-lasting decelerations mediated by baroreceptors, when chemoreceptors are stimulated, it takes longer to recover back to the original baseline heart rate. This is because fresh oxygenated blood needs to reach the maternal venous sinuses to remove the stimulus to chemoreceptors. Due to delayed onset and recovery, they are termed late decelerations and are often associated with fetal metabolic acidosis. Therefore, deceleration secondary to the stimulation of baroreceptors will be in relation to compression of the umbilical cord and will have a sharp drop and a quick recovery. The duration between the onset and nadir of a variable deceleration is often shorter than 30 seconds, and the total duration of the entire typical variable deceleration should be less than 60 seconds. On the other hand, deceleration secondary to chemoreceptors stimulation due to metabolic acidosis have a more gradual fall from the baseline and take longer, take longer to recover to the original baseline fetal heart rate. Therefore, due to their delayed recovery to original baseline, they are called late decelerations. Role of sympathetic system and the fetal adrenal glands in response to persistent and ongoing hypoxic stress. Fetal adrenal glands secrete catecholamines, adrenaline, and noradrenaline that have sympathomimetic activity. Catecholamines not only progressively increase the fetal heart rate, but they also cause peripheral vasoconstriction in order to achieve effective redistribution of blood to selectively perfuse vital organs at the expense of peripheral tissues and as a non-essential organs, and this is called centralization. Therefore, when interacting a CTG trace, an attempt should be made to scrutinize for slowly increasing baseline fetal heart rate over a period of time to recognize fetal catecholamine response to a gradually evolving hypoxic stress. The baseline fetal heart rate of 110 to 160 beats per minute should not be considered normal during labor for all fetuses, and the baseline heart rate for each fetus should be used as his own control. For example, a fetus may increase the heart rate from 110 to 150 beats per minute due to catecholamine release secondary to ongoing gradually evolving hypoxic stress, but still be within the normal range of 110 to 160 beats per minute. The somatic nervous system. Fetal movements cause a transient increase in fetal heart rate, which is seen on the CTG trace as accelerations. However, some studies have shown the presence of accelerations even after inducing fetal paralysis, and therefore they are not always associated with the fetal movements and appear to reflect the integrity of the somatic nervous system. Therefore, the presence of acceleration suggested the integrity of the somatic nervous system, and a healthy fetus not only has sufficient reserve to supply to central organs, but also has sufficient glucose and oxygen to expand on non-essential somatic activity. Hence, the presence of acceleration is a hallmark of healthy non-hypoxic fetus. A fetus attempts to compensate for ongoing intrapartum hypoxic initially by the onset of decelerations to protect the myocardium. The next step in the evolving hypoxic process is to conserve energy by reducing the movements of the movement by reducing the movement. A fetus attempts to compensate for ongoing intrapartum hypoxia initially by the onset of decelerations to protect the myocardium. The next step in the evolving hypoxic process is to conserve energy by reducing the movements of skeletal muscles. This will lead to the disappearance of accelerations on the CTG trace. In normal conditions, a fetus will have sympathetic and parasympathetic nervous system constantly interacting with each other, which will define the baseline and variability in the CTG trace. During labor, as a fetus is exposed to uterine contractions, a progressive intrapartum hypoxia may develop, which would trigger fetal compensatory mechanisms. Fetus will experience decelerations secondary to umbilical cord or head compression. Decelerations resulting from hypoxic stress will progressively become deeper and wider with continuation of labor. Moreover, a fetus will reduce its movements, and therefore accelerations may disappear from the CTG trace. If hypoxia continues to increase, a fetus will secrete catecholamines that will progressively increase the baseline fetal heart rate to compensate for ongoing hypoxic stress by obtaining oxygenated blood from the placenta to redistributing this blood to essential organs at a higher baseline heart rate. If decompensation sets in, loss of baseline variability may be observed, indicating hypoxia to central nervous system, followed by myocardial hypoxia and acidosis, leading to a progressive fall in baseline fetal heart rate, and this is called the stepladder pattern to death, culminating in terminal fetal bradycardia.